So like Dr. Warshaw said, I'm Kim Christophe. I'm one of the PGY5 EMIMs. And somebody just say wow. And I'm going to do a CCM talk. We're going to talk about the critically ill patient in general, kind of an intro to the year for CCM. So, oops, hold on. Okay, there we go. So we'll start with a case. I know usually we do the case kind of interactive. We're going to do some interaction later on this time. So I'm going to go through the case pretty quickly, okay? So we start with a 55-year-old gentleman. He's got a cough, he's got fever, shortness of breath, going through the ABCs very quickly. He's got a patent airway. His breathing is labored. He's using accessory muscles. His extremities are warm, and however, his capillary refill is more than 2 seconds. And for D, he's alert, he's oriented, but he is a bit somnolent. His vital signs are notable for tachycardia to 110, blood pressure at 80 over 55, respirations of 30, temperature of 101.5, saturating 84% on room air, and his blood glucose is 220. So preliminary problem list for this guy, we've got tachypnea and hypoxemia, we've got tachycardia and hypotension, we've got fever, and we've got hyperglycemia. Moving right along, our initial interventions for him, given his initial problem list, is supplemental oxygen, start with nasal cannula, go from there, put him on a cardiac monitor, establish a peripheral IV access, give him a saline bolus, get an EKG, a blood gas, and do a bedside ultrasound. We get a little more history from him. He says he's had productive cough and shortness of breath for the past 2 days. He's got no recent travel, no known sick contacts. His review of systems is notable for positive for headaches, lightheadedness, fever, chills, nausea, vomiting, diarrhea. Pertinent negatives, no hemoptysis, no leg swelling, no abdominal pain, no dysuria. His medical history is only notable for non-insulin dependent diabetes, for which he is on metformin and glipizide. So his exam, overall, the main things that it's notable are for our dry mucous membranes. He's tachycardic, although he does have otherwise normal heart sounds. And his pulmonary exam, he's tachypnic, he's got retractions, and he's got decreased breath sounds in the right lung. Otherwise, he has poor skin turgor. Differential at this point includes pulmonary embolism, sepsis, possibly pneumonia, or maybe an aspiration syndrome. So reassessing this guy after initial interventions, he says he feels a little bit better. However, his heart rate is still 110. Blood pressure only came up to 90 over 60. His respirations are down to 24, and he's now saturating 95% on face mask. Bedside ultrasound shows B lines in the right lung. He's got hyperdynamic contractility, and he's got no pericardial effusion. He does have a pretty collapsed IVC. EKG for him, just sinus tachycardia, otherwise nothing particular. Gets further testing, basic labs, all the sepsis labs, including blood cultures, COVID test, chest x-ray, and a repeat VBG. Blood tests come back. The one I really want you to focus on here is the VBG. He's got a pH of 7.25. His PCO2 is 49.8, PO2 33, bicarb of 21. He's got a base excess of -6 and a lactate of 8. Consistent with like a respiratory acidosis with a concomitant metabolic acidosis. He is COVID negative, and his trope is also negative. This is the chest x-ray we get, which shows a pretty significant right mid-lung consolidation consistent with a lobar pneumonia. So the rest of his ED course, he gets vancomycin and peptazo, he gets some more fluid boluses, and he started on a norepinephrine infusion. He is upgraded from face mask oxygen to high flow nasal cannula and eventually to BiPAP, and he's admitted to medical ICU for the final diagnoses of type 1 respiratory failure or hypoxic respiratory failure, septic shock, and pneumonia. So kind of very brief going through that case just to talk about kind of what is a sick person, because that's kind of what we're going to talk about today and what do we do with them. So we're going to talk about what's critical care, who requires critical care services. why do we monitor patients in the emergency department? And then we'll talk a little bit about a few of the monitors that we do in the emergency department. So end-tidal CO2, pulse oximetry, and arterial blood pressure. So to start with, who is actually critically ill? We see a lot of patients, particularly when we're working in CCT, that pass through, but how do we know who's critically ill versus just kind of a little bit sick or just not doing so hot today? So you'll find a ton of different definitions depending on what society guidelines you look at, what hospital guidelines you look at. I really like this framework that came from a paper that Dr. Belyevskaya sent me that kind of just gives you a good idea of how to go about thinking about a critically ill patient. So first, is the patient likely to require advanced respiratory support? Are they going to need to be intubated? Perhaps are they going to need ECMO? Or is the patient potentially going to require support of 2 organ systems? Maybe acute renal failure, they're going to need a CVVH, and maybe they also have acute respiratory failure, they're going to need to be intubated. Or does the patient have chronic impairment of one of their organ systems? Maybe, say, chronic heart failure, maybe very decompensated COPD, and they're going to require support of another organ or organ system. Again, this is just a framework. This doesn't mean that these people all have to go to the ICU. Doesn't even mean they all have to stay in CCT. But when you're looking at your patients that are coming in and you're saying sick, not sick, sometimes, you know, it helps to kind of just have a framework to think about what kind of resources this patient may require, what their disposition might look like. And of importance, just even if you are, you know, working in a hospital, you see the guidelines for the ICU admission and it says, you know, this is exactly what it says. Maybe the patient comes in and they look like that. Maybe they look like a severely tight asthmatic. They're moving no air. And you think this person's critically ill, they need to stay in CCT. However, you know, you get them started on duo-nabs, you give them MAG, you give them DEX, you give them epinephrine, maybe some BiPAP, and sooner or later, they turn around and they're probably fine for the floor, you know. So just because someone is critically ill initially doesn't mean that they're critically ill later. And that's one of the main reasons why we want to monitor our patients. It's a little bit of a silly question, probably, like, why do we monitor our patients? We monitor them because they're sick and we want to know what's going on with them, right? But I think it's good to actually think of a concrete reason why we're actually monitoring them. Why are we ordering these monitors? So one reason is to guide our resuscitation. So initially, you know, some people talk about resuscitation endpoints. You know, sepsis, we're looking at the lactate, is it coming down? But I like to kind of think of resuscitation guide points. Like, what are we aiming for? Doesn't mean that we have to get there, but we want to move towards it. And so I like this chart to kind of give us an example of what some of those kind of resuscitation guide points might be. So for instance, in maybe a hemodynamically unstable patient, we want to move towards improving the delivery of oxygen to the tissues. And so that's your DO2 at the top. And in order to do that, we're going to try to improve or optimize our cardiac output via optimizing stroke volume and heart rate. We want to make sure that their oxygen saturation of the blood is appropriate to be able to deliver to tissue. So we want to optimize our hemoglobin concentration, optimize our oxygen saturation. And so it's just a way to think about what are the things that I'm monitoring so that I know what I'm moving towards. What do I want to try to make better? Another reason why we monitor our emergency department patients who are critically ill is because of ED crowding and ED boarding. And so when I say that, what I mean is patients who are dispositioned to an inpatient team, but they're living in the emergency department for a prolonged period of time. So ED boarding of critically ill patients has been increasing over the past several years. And what we see is that across the board, whether it's critically ill patients or not critically ill patients, outcomes are actually worse for patients who board in the ED for longer periods of time. So for instance, in a paper by Chalfin, they looked at ICU destined patients who boarded in the ED for longer than 6 hours, which is this column, and less than 6 hours. And you can see that there was a significant difference in terms of ICU mortality as well as all-cause kind of hospital mortality. And so part of what we can do to mitigate that is make sure that we're keeping an eye on those patients when they're in the emergency department so that we can tell if they decompensate, if they need an acute intervention. That potentially can mitigate that kind of long-term, less than optimal prognosis given their ED boarding status. So this is kind of like what our monitors look like. There's a bunch of numbers, there's a bunch of waveforms. Often I think, you know, we kind of focus on one, not necessarily the other ones, but we tend to kind of order them all together. What I really want to emphasize is that, you know, when we're ordering cardiac monitoring or pulse oximetry, we want to have an idea in mind of what we're actually looking for. We want to have an idea of why we're ordering that lab so that if that alarm goes off, we know what we want to do with it, so that we know that, you know, actually this guy, his heart, he's a great athlete. His heart rate is usually, you know, 45. He's an Olympic, you know, triathlete. Let's change those parameters, and so that I can respond when I actually am concerned. You know, not putting in, we've got a, you know, an arterial line tracing on here, not doing it just for the procedure, doing it so that we know that we're really aiming for a good outcome for the patient. So the first type of monitoring that we're going to talk about is pulse oximetry. Everyone gets pulse oximetry, it seems like, especially recently with COVID. So what are some reasons that we might use pulse ox? Acute cardiovascular decompensation, acute dyspnea, kind of undifferentiated dyspnea, any kind of assisted ventilation, whether it's non-invasive or invasive, we're probably going to have people on pulse oximetry, any kind of titrating of oxygen therapy, altered mental status, just to kind of keep an eye on them if we're not quite sure what's going on. And so when we think about pulse oximetry, we want to kind of go back a little bit to med school, or maybe this is pre-med school. Remember what pulse oximetry actually is and how it works, because that's going to help us remind us what those limitations of pulse oximetry are and when we maybe need to reassess and use something else to supplement our pulse ox. So if you recall, in the blood, we've got deoxygenated hemoglobin and oxygenated hemoglobin. And one of the laws that pulse oximetry runs off of is that you can tell the concentration of a substance by the amount of light that is absorbed at a specific wavelength. And so oxygenated hemoglobin absorbs light really well at 940 nanometers, and deoxygenated absorbs it really well at 660 nanometers. So basically pulse ox shoots out light at 660 and 940 nanometers, and then sees kind of what passes through or reflects off the tissue and makes an assessment from there. In a very simplified manner, it essentially makes a ratio of the deoxygenated to oxygenated, looks at a database and says, in healthy people who have this ratio, this is what their oxygen saturation is. Very simplified. But what's important to recognize is that the pulse ox is operating off of the arterial pulsations. That's what it's measuring. It's not looking so much at the venous blood. It's kind of subtracting that from what it's measuring. And so that's important to recognize. So with that in mind, what are the limitations of pulse ox? Again, we're looking at absorption of light. So remember back to med school with your carboxyhemoglobin. Carboxyhemoglobin absorbs light the same wavelength as oxygenated hemoglobin. So it's often read as oxygenated hemoglobin, you get a falsely elevated saturation. On the other hand, something like methemoglobin actually absorbs light at both wavelengths. So what the computer reads that ratio as is kind of 1-to-1, which goes to a saturation of 85%. And so if your patient is saturating truly, has a true sat of 60% or 90%, it's going to move towards a reading of 85%. Severe anemia with hypoxemia is a limitation. So that's to say that someone who has severe anemia, I don't mean necessarily 8, but low hemoglobin, who also is hypoxemic, may have a falsely low reading. So they may be truly saturating in the 70s, and they may be there, but their reading is going to be much less. If that patient is saturating normally, they actually have a normal saturation, they're normoxemic, there's not generally an issue with reading the pulse ox. For hypotension, for vasoconstriction, those are going to be often falsely low readings because, again, remember, you're working off of arterial pulsations, so not being able to read the pulsations are going to be reasons why you're going to have falsely low saturation. Again, if you have something that's causing venous pulsations, so say you have the pulse oximetry on someone's head and they're in Trendelenburg, then the pulse ox may pick up venous pulsations as arterial pulsations, and you may get a falsely low reading on your pulse ox. Nail polish, we often talk about nail polish. It's actually not as big of a deal as it used to be. Modern pulse ox machines actually are pretty well able to work even with patients with nail polish. Artifact from movement, we always see that when patients are moving, you see these crazy waveforms, but what you may not recognize is that sometimes if you have a good waveform on the pulse oximetry, but the patient has a tremor, the pulse ox may read those tremors as pulsations. And so you may get false low reading in those instances. Big one that I really want to emphasize is delay. So there's some really great videos on the internet of people holding their breath for, a full minute and having a pulse ox on, and the saturation doesn't start to drop for seconds to minutes. And so that's something to think about. So when you have those patients, maybe you're doing a procedural sedation and you have them on pulse oximetry, they can stop breathing and you may not pick it up for several seconds to even up to a couple of minutes later. So that's something to really keep in mind. They can be a little bit different. The delay is a little bit different depending on whether you're monitoring it centrally or peripherally, but it's still going to be a delay. Finally, accuracy in severe hypoxemia. So pulse oxes are really calibrated to 70–75% and above. Anything lower than that is not necessarily going to be accurate. That said, whether your patient is saturating, 67% or 50%, it's not. You don't necessarily have to know the exact number from your pulse ox. They need intervention. And then one of the things that has kind of gotten a lot of attention recently is the issue of skin pigmentation. This got a lot of attention with COVID, and there is a significant amount of data that suggests that folks with darker pigmentation are more liable to have occult hypoxemia, meaning their true saturation is maybe in the 80s, but their pulse ox is reading in the 90s or above. So, again, taking all of this together, if your patient doesn't look like what you're reading on the monitor, think about some of these limitations and reassess, and maybe think about doing another assessment. Another assessment that you might want to add to that is going to be end-tidal CO2. We use it a lot in our procedural sedations to supplement our pulse oximetry, but there's a lot of other reasons why you might want to use our end-tidal CO2. We're going to use it in our ventilated patients. We are going to use it when we intubate a patient to double check that the tube is actually in the trachea. We're going to use it during CPR sometimes. It can be useful in recognizing that you're doing adequate compressions and in recognizing ROSC earlier, as well as there is some data that there's some confounders in there, but it can be used to make determinations about prognosis. Is this person likely to get ROSC or survive? Finally, we use it in patients who are altered, intoxicated sometimes to just assess their ventilatory status. It can be really good to see, maybe this acute intox. We just want to kind of make sure that they continue to breathing, and the end-tidal CO2 is a good way to keep an eye on that. Use it in acute respiratory insufficiency of whatever form you could use it. And then again, in procedural sedation. So when we talk about end-tidal CO2, we've got capnometry and we've got capnography. So on your screen right now, you've got capnometry, meaning you get a number, but you don't get a waveform. So on the left, you've got your color change capnometer, which is semi-quantitative. You've got the numbers around the outside. It's initially purple. That tells you you've got a end-tidal CO2 of less than 4 millimeters of mercury. When it changes to bright yellow, that means you've got at least 15 millimeters of mercury. And we'll talk a little bit more about that later. This over here is a digital portable capnometer that can go, say, on the end of an ET tube. You get a readout of the end-tidal number, meaning the peak number, but you don't get any kind of waveform that tells you what's going on. Unlike with capnography, which this is a portable capnographer, you get an end-tidal CO2, so the peak end-tidal, as well as a waveform down here that will give you a little bit more information. Within the kind of category of capnography, you've got a couple of different types. You've got your mainstream, you've got your side stream. So essentially, it just basically depends on how the exhaled gas is being sampled. So here you've got a mainstream capnography. So this is a little plastic piece, connects to the end of an ET tube, and then there's a device that actually is the sensor, and that clips onto the plastic piece. The great thing about this is the exhaled air is going directly through it, so you're directly measuring the exhaled air. It's a more accurate, it is a very immediate reading because the air is right there. The only issue is that they can be tough to use in patients who are not actually intubated. Your alternative is your side stream. These are what we often, I think, use. This one here can go on the end of a ET tube, just like the other one. But what happens is you've got this little tube here on the side. And this long tubing connects to a pump that basically aspirates puffs of air as it's being exhaled, and then sends it to a sensor that detects the amount of CO2. So the issue, as you might imagine, is that it's going to be a little bit of a delay. So you don't get quite as an immediate reading, which is the same with this is also a side stream. This is the nasal form. And so it just kind of puffs takes little samples from the air and sends it over to a machine. Issue with these is they can get clogged. The tubing can get clogged easily. The sensors can kind of clog. And again, it's not as immediate. So when we're looking at our end tidal capnography, this is our main waveform. So just to go through it briefly, jog our memories, we've got phase 1 through 0. Starting with phase 1, we've got our dead space expiration, so nothing that's participating in gas exchange. Phase 2, we get a fast, rapid rise on our CO2. And phase 3 is our alveolar phase. So basically all the gas from the alveolus is kind of equilibrating here. It's either going to be a plateau or a small steady rise like this. And at the end of it, our peak is our end tidal CO2. And then as the patient inhales, you get phase 0, it drops back down. It should drop down to 0. So when you're looking at these waveforms, you want to look at the shape, you want to look at the rate, you want to look at the trend and the end tidal. So if you've got a patient and you've got an end tidal on them, and this is the waveform that you see, tell me about the rate, the end tidal, the shape, the pattern, what you think might, the cause might be. Anyone? Any of those things?
The rate is variable, and also the expiratory phase, the alveolar phase is also variable. It seems to be prolonging as the breaths are continuing with longer expiratory phases.
Yeah, exactly. So basically, yeah, so longer expiratory phases, which correlates with a slowing of the respiratory rate, as well as a rising end tidal CO2. Remember, this is your end tidal CO2, this peak. And that's kind of slowly rising over time. The shapes look pretty good, right? They look pretty much like the one that we looked at before. So this is going to be what we call a type 1 hypoventilation, or a bradypneic hypoventilation. Decreasing respiratory rate, increasing end tidal CO2, prolonged alveolar phase, and this is kind of like your opioid oversedation. You look, yeah, makes sense? Okay. So how does this compare to this end tidal CO2 when we look at the rate, when we look at the end tidal, when we look at the shapes, the pattern? Let's see. Zara. And what about the shape? Okay, yeah, so for folks in Zoom, so said the rate is pretty consistent. The end tidal drops suddenly. The shape looks pretty normal. And so that is consistent with a type 2 hypoventilation, or a hypoventilation, meaning you've got regular ventilation, then suddenly you've got a drop in essentially the depth of ventilation. So this is often seen with sedative hypnotics. And what's happening is the patient is taking very shallow breaths, although their rate doesn't change. And so the end tidal actually drops dramatically because most of the expiration is not actually really participating in gas exchange. It's primarily dead space ventilation. And so this is something you want to keep an eye on. All right, moving on. You've got a 45-year-old gentleman. He's undergoing procedural sedation. You notice that he's got raised red lesions on the skin, and this is the end tidal that you notice on the screen. So talk to me about the rate or the shape or the end tidal. Someone in the back, Ryan.
So the rate looks okay. I guess the end tidal is not really changing, but your shape is changing. I get more, I guess, I don't know, this the shark fin appearance.
Yes.
Obstructive situation.
Exactly. So Ryan nailed it. So this is your obstructive pattern, your bronchospasm. So what you're seeing is the rate looks okay. The end tidal actually looks okay. However, you've got this weird shark fin appearance, and what you're having is kind of a slurring of the rapid rise that's supposed to go straight up into the alveolar phase because of the prolonged expiration, the bronchospasm that's happening. And so that would be concerning if you were to see this suddenly appear on a patient that you had under procedural sedation. And one more important one is this one. You've got a 74-year-old gentleman, CPR is in progress, he's intubated, the color changes after a couple of breaths, and then this is what you see on the end tidal. Let's see. Oh gosh, I don't know most people's names back there.
Find it out.
It's so good. Let's see, it's center in the blue. Yes. There you go.
So it doesn't look like the rates that even.
Okay.
And the shape's not there either, and the end title's not as high as the previous ones.
Okay. Absolutely. Any thoughts about what might be going on or what you might need to do? It's totally okay if you know.
Just the two.
Huh?
The two locations.
Oh, what about it?
Into the right view.
Okay, so you're on the right track. For Zoom, basically the answer was that, basically nothing looks normal on here. And the concern was about the location of the tube. And that's completely correct. However, this is your esophageal intubation. So what we're seeing here is that after a couple of breaths, you got color change on that and on that end tidal colorimeter. Really important with those. You've got to do at least 6 breaths, 10 if you can, get yourself to do it. If someone drank a carbonated beverage right before you intubated them, you're liable to get color change. You're also liable to get false negatives though. If someone has a prolonged downtime, you can get a false negative. Think you're in the esophagus, but you're actually in the right place. That's why, actual seeing a waveform is really helpful because here you've really got nothing going on here. And even sometimes you may initially see with those first couple breaths, you could see a somewhat decent waveform, but it's going to pretty quickly kind of drop off. And you're going to know that you're in the wrong spot.
The other thing, Kim, is that let's say as your CPR is going on, let's say you are in the esophagus, and then you change it. Now you know you're definitely ventilating, but you're still not getting good PCO2s as you go along. As per the ACLS guidelines, that means your CPR might not be good enough. Right? Because you want to get a PCO2 that's way over 10, approaching 40.
Yeah.
Especially if you achieve ROSC. You want your PCO2 usually, if you achieve ROSC, you'll see jump up to near 40.
Yeah.
So that's for example, Gersheimer's giving the CPR, and you're seeing that, you'd say, get out of here, Gersheimer, let somebody like Rich Sennett, who's much stronger.
Absolutely.
Right, Rich?
I'm just picturing Sennett doing CPR.
Absolutely. And so, yeah, so along the lines of what we just discussed, colorimeter is, it's great in a pinch. It's great to get your immediate, but it's good to confirm with other things where you actually are. End tidal is great. However, the issue is that if you've got someone who's going to be on prolonged end tidal, say a ventilated patient, it is good to sometimes get an actual blood gas to see what their actual PaCO2 is, because your CO2 on your end tidal, it may correlate, you know, you can see the trends, but you're not necessarily going to have an actual accurate number of what the CO2 is. And so, you know, for procedural sedations, things like that, it's generally not an issue because you're just looking at the trend. But beyond that, you may want to correlate it. Additionally, low tidal volume respirations can be an issue. So if you're using one of those nasal end tidals, sometimes what happens if a person starts taking really small breaths, what might happen is that you might just start getting air from the sort of ambient air entrained into the system, and you might start getting some falsely low numbers. It's best for isolated disease. You don't necessarily, people who may have a metabolic disease and a perfusion issue and a respiratory issue, it may be a little bit difficult to correlate end tidals in those cases. Oops. Yeah. So moving on to the final type of monitoring that I'm going to talk about is, it's going to be blood pressure monitoring. So we use non-invasives on just about everyone, right? They're great. And for 90% of our patients, they're completely fine, probably 95% of our patients. The issues with them, though, is that you have variable accuracy. Basically, whether you're using a manual cuff or an automatic cuff doesn't mean it's necessarily accurate. With manual, people do it differently. People hear the sounds differently. And with an automatic cuff, depending on the actual algorithms and the technology of the machine, you may not actually get accurate numbers. In addition to that, body habitus, arrhythmias can all play into not quite getting accurate assessments of someone's blood pressure. And so in those cases, you may want to look at doing invasive blood pressure monitoring with an arterial line. So the biggest reason for us in the emergency department probably to acutely put it in is when we have someone who it's vital that we really have an accurate blood pressure, and we just don't think that the non-invasive cuff is giving that to us. Again, probably 99% of our cases, we don't necessarily need to do that. Monitoring CPR, just like with end tidal, can be very useful, especially in looking for ROSC. When we have someone who's going to be on prolonged vasoactive medications, which again, this is more of an inpatient setting issue, but that might be a time that someone may need to have an arterial line placed. Someone who's getting frequent blood sampling, maybe they're very hard stick and they're getting Q2 hour labs drawn, maybe that might be someone who needs it. And then advanced cardiac interventions, you may need it if you're setting up ECMO, if you're setting up a balloon pump, looking for a blood pressure on someone with an LVAD. So what exactly is the arterial line? We see them, we look at the number, but how much do we actually think about what's going on and what we're actually looking at? So the basic premise for the arterial line is that you've got a solid column of fluid that goes from the artery to the detector. And any pulsation on that column of fluid is detected against the pressure transducer and translated into a number. So we've got our catheter that goes directly in the artery. We've got our non-compressible tubing, extremely important to have non-compressible tubing. We've got our pressure transducer that attaches to the monitor and gives us a reading. And we've got our pressurized bag of saline. It's going to be pressurized to anywhere between 250 to 300 millimeters of mercury. And again, we have a solid column of fluid from the pressure bag down through the pressure transducer to the artery, so that all these pulsations that are occurring are causing waves to go through the fluid to the pressure transducer. So this is kind of the general waveform that you're going to get. The main thing that I really want you to focus on is this notch here, the diacritic notch that you may recall. Everything before this is you can think of as systolic. Everything after this you can think of as diastolic. And the diacritic notch is, for lack of a better explanation, you can think of as the aortic valve closing. So this is again, your general waveform. Your waveforms are going to be a little bit different, maybe taller peaks, shorter peaks, a little more rounded, a little more peaked, depending on the age of your patient, comorbidities, where in the body you're doing it. Is it a femoral line? Is it a dorsalis line? And that's going to change things. I won't go into that too much right now, though. So thinking about that waveform, if you've got this waveform and a 67-year-old gentleman with who has now achieved ROSC, is on 15 mics of Levofed, and you have an arterial line in because that's what you've decided is necessary, and this is your waveform in red. How does that compare, or what do you think might be going on? How are you going to respond to that waveform? And Ryan. Oh, not Ryan, sorry. Why did I just say Ryan? David.
So
It's okay.
I'm assuming that means it's about 80/40 is the arterial pressure. So you could increase your Levofed.
You could. Or you could double check that your line is working accurately. So this is kind of your classic overdamped arterial waveform. So remember this notch, this diacritic notch that you're looking for. There's no notch here. You're just kind of going up and down here. So what this means is that basically there's something in your line that's absorbing all those pulsations. And so the monitor is not reading it. So it's going to give you a falsely low systolic, falsely high diastolic. Although the map is probably going to be about accurate. So what you're going to do is you're going to check your line. You're going to do a fast flush test, which I'll show you in another slide. And then you're going to check your tubing for air bubbles, looking for clots, and you're going to check that you didn't accidentally put IV tubing instead of arterial line tubing. And you're going to correlate it with the non-invasive. This is going to be your underdamped reading. So it's going to be the exact opposite. You see all these crazy pulsations everywhere. Things that are going to cause this are going to be, usually it's excess length on the tubing. So when you get one of those two readings, what you're going to do is this fast flush test, which is just a quick flush, pressing the flush on the pressure transducer, sends fluid through it. You get a nice square wave here. And what you're looking for on the monitor is you want two little oscillations right after it before it goes back to its regular arterial line reading. And that means it's damped in the right way. Underdamped, you'll get less than 2. So kind of 1, maybe 1.5, maybe 1.5, but it's going to be kind of a lazy waveform. And then if it's overdamped, you're going to get more than 2 before it goes back to its usual. And that's kind of what you want to look for. The other way that you want to troubleshoot your arterial line when you get a reading that you're not sure about before you respond to it is checking that your art line is leveled and zeroed. So zeroing the waveform and zeroing your line essentially means you're going to uncap the line right at the pressure transducer, expose it to the atmospheric air, zero it on the monitor, and then close it back up. But what is often the issue is leveling it. There's this important axis, fluostatic axis, it's about at the right atrium. And it's technically the mid-axillary line, 4th intercostal. And your pressure transducer needs to be at that level, unless it's stepped in special scenarios. But in general, that's where you want it. And what happens if your patient's bed is on the floor and the pressure transducer is up here in the air, you're going to get a falsely high reading. And on the other side, if your patient's bed is up in the air and the pressure transducer is down on the ground, or sorry, I totally confused that. If what did I say?
If the
sorry.
Is low, you have to wait to the column.
Yeah, right. You get high, right? Okay, sorry. Yeah. So if it's below you, you get a high reading. If it's above, you get a low reading. Yes. Okay, so that's what you want to look at. So we talked about a bunch of different types of monitoring of our critically ill patients. The things I really want you to take away from this, beyond the details, is really one, individualize your patient alarms. Think about why you're ordering monitoring. Have a reason for it. Order only what you need and respond to the alarms that occur. Second, think about the limitations of your pulse ox. Again, we use it on just about everyone, but it doesn't mean it's accurate on everyone. So think about it. If it doesn't look like what the patient in front of you looks like, think about the limitations and maybe move on to something else like end tidal or doing a blood gas. Consider end tidal, again, as a supplement to pulse oximetry. And when you're using end tidal, look at the waveforms, look at the shape of the waveforms, because that's telling you a lot. It's not just the number, it's the waveforms. That's going to give you a lot of early information about what's going on with your patient during procedural sedation. If they stop breathing, you're going to see a change in the waveform before you get a change in the pulse ox. And finally, if you're using an art line, kind of think about how to assess and troubleshoot it before you immediately respond to a number. Look at your waveforms, and if you're not sure about exactly how to troubleshoot it, just ask someone or Google it. But before you start futzing with the amount of Levophed you're giving or the amount of vasopressin, make sure that you troubleshoot it. These are my references, and thank you so much to the CCM team who got me through this.
That was terrific. That really was a great presentation. You knew your stuff so well. You hardly had to look at your slides. That was really great. I thought the way you presented it was just really a classical way of presenting. I like your style so much. Just one comment, which has nothing to do with your lecture, it just has to do with my lecture from last week. But that patient that they presented, I would have probably added on to that coverage. They're worried about staph and Pseudomonas. I could see them using that coverage. I would have also worried about Legionella. And I would have actually added on a macrolide, or if I couldn't add on a macrolide, I would have used something like levofloxacin or respiratory quinolone. That's the only thing I would say. But that case was suggested that it could have been a Legionella. And until you get urinary antigen or anything back, you should cover for it.
Yeah.
That had nothing to do with the lecture.
Excellent. I think that you hit a lot of really good points, and like Dr. Gernsheimer said, you really simplified it. That's great. I think I just want to emphasize what you said. Look at the patient, right? Look at the patient. It's so important. Who are you resuscitating? Are you resuscitating somebody with terrible protoplasm or somebody who's very athletic? And so these are all supplemental ways of helping you come to that assessment. But look at your patient, and know what the physiology of your patient roughly is, and that's going to help you quite a bit. So many times you see people acting on waveforms that are all over the place, and it really, that's a very key point, especially for the junior people. Thank you.
I think Dr. McKee is kind of one step further. As soon as the patient comes in, you should put your finger on their wrist. You can feel their rate of pulse. You can feel the uprise of the pulse and see if it's damp or if it's very bounding. You can also feel the temperature of their skin, and then look at their respiratory rate while you're doing that. And you have their vital signs before the nurse even gets near the patient. But you'll be ahead of everybody else if you can train yourself to do that every time you see a patient. Check their vitals yourself and get used to doing it.
The other thing I was going to say, Kim, Dr. Silverberg made me think about it. The first vital signs you showed up there with somebody who was 80/60 with a heart rate of 110, that would scare the daylights out of them, unless they live with a heart rate of 50, right? If you're dealing with Serena Williams, who lives at a heart rate of 35, 110 is unbelievably tachycardic. But if you're dealing with, and a lot of you don't know who it is, if you're dealing with Dom DeLuise, who lives at 120, this person's about to go down on you because they're not compensating well enough for that 80/60. Do you know Dom DeLuise?
I know the name.
Oh, okay.
That was really well done, Kim. I think almost all of these monitoring devices have a corresponding non-invasive way. Classically in procedural sedation, just observe for chest rise, and then now all of a sudden we have end-tidal CO2. You mentioned one thing about the end-tidal CO2 about getting a PaCO2. It could be venous.
Right.
Or PaCO2 just to emphasize when you need the arterial stick. But the end-tidal CO2 we use much more often than the A-line, and this is hopefully not to promote A-lines all of a sudden, because I think it's pretty uncommon that we need it, but when we use the end-tidal, there are so many indications and there's so many pros and pitfalls. So for example, if you have somebody who's on a ventilator, we have a ton of patients on ventilators in the CCT or downstate in the resus room, they're there for several hours. You walk by the room, there's an end-tidal perfect waveform, and it's at 80. You have enough information to intervene by approaching the ventilator and making some changes with the respiratory therapist. And then you can see the changes immediately, actually within a few minutes. You'll see the response to your initial treatment. And again, the A-line, if somebody is on levo, vaso, epi, and then all of a sudden we're adding on phenylephrine dopamine, we really have to see, are we causing harm? Is the data that we're trying to obtain, is that giving us accurate data? Is our treatment, is our response to that appropriate? It's not going to be appropriate if the data that we're getting from that A-line is inaccurate. So those are really important points. I'm really glad you talked about that. That was a really great presentation.
Great job.